A very good day, my dear postgraduate students and junior faculty. A question is staring at us right on the face. Pringer, Kuchinka, lymphadenitis. Do not open your cell, the net, or your book. Answer this. And believe it or not, it is a university question. That is why I had chosen this. Welcome to SNIP, Short Notes in Pathology. The history behind, as I usually say. Again, a very great person, Dr. Alexandra Pringer, Kuchinka, 1912 to 2004. She was the person who identified this, and hence it is rightly called after her name as Pringer-Kuchinka lymphadenopathy. And the literature goes on to say that she was an outstanding pathologist, an inspiring teacher, and a tireless researcher. What more do you need? And she was the person to accurately describe toxoplasma lymphadenitis way back in 1952, even before I was born. And it was a protozoan infection caused by Toxoplasma gondii. The rest of it we shall be seeing in the subsequent slides. This is what made me go to that particular class. We were having a slide. It was a patient with a similar history, somewhat weird. Here and there lymphadenopathy, but then there was no strong history. When we studied the slides, it showed some features. Look at this one. There is a definite but unequal follicular hyperplasia. In some areas, I am able to see a starry sky-like pattern. And also, there is a monocytoid B-cell hyperplasia that can be seen. Adding to all of this, I am able to see a maze of pale areas which are probably the histiocytic zone. So I find that there is a reactive lymphocytosis and a sinus histiocytosis. They say that in addition to that, there can be some epithelioid histiocytes, maybe an attempted granuloma formation. I hope this picture is quite clear for you, courtesy pathology outline. Again, I would like you people to appreciate and write all these features, such as the follicular hyperplasia, the parafollicular B cells, the starry sky pattern, sinus histiocytosis, sometimes. In fact, it is supposed to be a stellate question. The stellate abscess is classical of toxoplasmosis. And ill-defined necrotizing granuloma may be seen. Langerhans cells to add fuel to the fire may be present, and it was there in our case also. But all the other investigations for tuberculosis were negative. Look at this over here. Definitely, it's a cat of all traits. So the cat is a definite host, and it is fed with by means of the mouse or the rat. And you find that these are being shed by the cat after about 2 weeks of infection. And it goes on to the field where it is being consumed by the animals. And also the intermediate host, the rat. The cycle goes on. And wherever there is a contamination, you find that man happens to be the end stage or the intermediate host again. So this you should be remembering. It is quite easy. There are 3 stages. The trophozoite, earlier called as the tachyzoite, bradyzoite, and the oocyst. The oocyst is what is developing within us, and it leads to sexual reproduction. Again, a beautiful cycle. You find that this is the organism, somewhat spindle-shaped or sickle-shaped, whatever it is. And here you find the oocysts are there in the cat's feces. It goes on to the grass, and it contaminates the vegetables as well as the other organisms and also the cattle. Obviously, these are a source of infection to man, and you find that they do get infected. Sexual transmission is also possible, leading on to a vertical transmission to the fetus. And leave alone, you find that it can affect various organs and can be transmitted by blood also. So this is a beautiful diagram which you people shall and will have in mind. The histology, as I told you earlier, I find that there is a irregular hyperplasia of the lymphocytes, and they are separated by a maze of the sinus histiocytes. In some areas, there is an accumulation of the foamy histiocytes, maybe an attempted granuloma formation. The other features I had mentioned. The cysts of the toxoplasma are hardly seen in the tissue. Then how do you diagnose it? We shall see. Going on to the sites. Toxoplasma gondii has invaded many a tissue, and the lymph nodes are the most common. The posterior cervical lymph node, as is mentioned over here, is characteristic. The other organs can be hepatosplenomegaly is quite unusual. There can be the other lymph nodes which can be involved. The skeletal muscle, myocardium, brain, and eyes. So look at this one. The brain is being involved, and this is before the treatment, after the treatment, which means it can be controlled. And man as a dead end remains through. The clinical features are, in whom does it develop? Mainly in immunocompetent or immunocompromised patients. Immunocompetent, but then they are treated with the steroids and other things. Whereas immunocompromised can be HIV. And you find that the CNS can be involved, there can be myocarditis. HIV is again one of the prototype causes for it. There can be a congenital, the vertical transmission, and the third trimester is at risk. Rarely there can be ocular, as is shown in this picture, courtesy eye rounds, chorioretinitis. The laboratory diagnosis, always for any of the questions, make a list by yourself. It will be quite easy. Sabin-Feldman dye test. A difficult name, but okay, try to remember. Immunofluorescence. Direct is not possible because we require the live organisms. Therefore, indirect immunofluorescence. Immunoassay for the antibodies. IgM and IgG antibodies. Latex agglutination test. ELISA we all know, and PCR we can write. So it is quite easy for us. So this is the standard ELISA and the pan ELISA toxoplasma antibody, and this is the colored substrate with which you identify. And this incidentally is the final summary of it. Toxoplasma gondii, as it is called, how it is being transmitted. The cat is the main killer here. And you find that the various modes of transmission are there. The tissues that can be affected, including the heart, the kidney, the brain, blood again. And you find that there are the methods of diagnosis which we had seen in the last slide. Thank you.